Hello, everyone, and welcome back to Study Nurse IQ. I'm Jenny. Today, we are diving deep into a truly critical cardiovascular topic: aneurysms. This is a condition that is often silent, but when it becomes symptomatic, it is a life or death emergency. As nurses, knowing how to recognize the subtle signs and what not to do is absolutely key to saving a patient's life. Stick with me until the end because I've got 3 NCLEX-style questions to test your knowledge on the most vital nursing priorities for this topic. What exactly is an aneurysm? Imagine a balloon suddenly forming on a sturdy garden hose. That's essentially what an aneurysm is. It is a balloon-like bulge or localized dilation in the wall of an artery. This bulge occurs because the arterial wall, which is normally thick and strong, becomes damaged and weakened. Pathophysiology. This weakening can happen for a few reasons. The most common is the chronic pressure damage from atherosclerosis, plaque buildup, and uncontrolled hypertension. The constant pounding force of high blood pressure against an already stiffened artery wall is what causes that wall to thin out and bulge over time. Other, less common causes include congenital disorders like Marfan syndrome, which affects connective tissue, trauma, or infection, though this is rare now. The biggest threat with any aneurysm, of course, is that it will rupture, leading to rapid, life-threatening hemorrhage. Risk factors. If you look at the risk factors for aneurysms, you'll see they heavily overlap with the risk factors for coronary artery disease. Why? Because they all damage the same thing: the lining of your blood vessels. Demographics. White males are statistically at a higher risk. Age. Older age is a major factor, as arteries naturally stiffen and weaken over decades. The big 3 damage factors. Atherosclerosis, plaque buildup, is the root cause of the wall weakening. Uncontrolled high blood pressure is what pushes that weak wall to the breaking point. Smoking. This is toxic to the artery lining and is one of the strongest modifiable risk factors. Other factors: elevated cholesterol, obesity, and connective tissue disorders like Marfan syndrome, which makes the arterial tissue inherently weak, also increase the risk. Types of aneurysms and their hallmarks. The signs and symptoms depend entirely on where the aneurysm is located. Remember, many people are asymptomatic. They only discover the aneurysm when they have a CT or ultrasound for something completely unrelated. Signs and symptoms: abdominal aortic aneurysm. The abdominal aortic aneurysm, or AAA, is the most common and often the most recognizable. It occurs in the lower part of the aorta, in the abdomen. The hallmarks: pulsating abdominal mass. This is the classic symptom. You might feel or see a pulsating mass in the mid to upper abdomen. Back or flank pain. The expanding aneurysm can push on other structures, causing pain that often radiates to the back or the flank, the side of the torso. Bruit. If you listen over the area with a stethoscope, you might hear a bruit, which is a swooshing sound caused by turbulent blood flow moving over the abnormal bulge. Critical nursing warning: do not palpate. If you suspect a client has an AAA, never vigorously palpate or press on the area. You do not want to risk rupturing the already thin arterial wall. Assessment should be gentle, relying more on listening for the bruit and observing for a pulsation. Signs and symptoms: thoracic aortic aneurysm, TAA. The thoracic aortic aneurysm, or TAA, is located higher up in the chest cavity. Because of its location, it presses on different structures, leading to a different set of symptoms. The hallmarks: severe back or chest pain. This is often the first and most alarming symptom. Respiratory distress. The aneurysm can press on the trachea, causing shortness of breath, dyspnea, and a cough. Dysphagia. It can also press on the esophagus, causing difficulty swallowing. If the patient suddenly develops severe, ripping or tearing pain in the back or chest, it suggests an impending or actual rupture. That's an instant emergency. Diagnosis, treatment, and nursing care. How do we confirm the diagnosis, and what is the treatment aimed at? Diagnosis. The easiest and most common ways to diagnose an aneurysm are through imaging. CT scan, computed tomography, provides a clear, cross-sectional image of the aorta, measuring the exact size of the bulge. Ultrasound, a quick, non-invasive way to measure the diameter of the AAA. Treatment goal: preventing rupture. Everything we do is focused on reducing the stress on that weakened arterial wall. Antihypertensives. This is the cornerstone of non-surgical treatment. We must tightly control the patient's blood pressure. If you have high pressure pounding against a weak wall, rupture is inevitable. The goal is often to keep the systolic blood pressure under 130 mmHg, but you must always follow the specific provider orders, as they may want it even lower. Procedures, surgical intervention. If the aneurysm grows to a certain size, typically 5 centimeters or larger, or if it is rapidly expanding, surgical intervention is necessary. Aneurysm resection or repair. The surgeon can either use a traditional open surgery approach or a less invasive endovascular approach, threading a stent through the artery. The goal is to essentially replace or reinforce the damaged section of the artery with a synthetic graft. Nursing care, post-op, and monitoring. Nursing care is vital for monitoring the patient both before surgery, watching for rupture, and after surgery, watching for complications. Monitor for signs of rupture. This is the most critical pre-op and post-op concern. Rupture is a massive internal bleed, and the patient will quickly crash into hypovolemic shock. Signs of this rapid blood loss include sudden onset of severe, excruciating pain, often described as ripping or tearing. Hypotension, blood pressure dropping fast. Tachycardia, heart rate going up to compensate. Diaphoresis, sweating, pallor, pale skin, and decreased level of consciousness. Extremely low urine output. Post-op monitoring. Closely monitor their vital signs, cardiac rhythm, and urine output. If the urine output falls below 30 milliliters per hour, it could indicate poor perfusion to the kidneys due to low blood pressure or clot formation, and you must notify the provider immediately. You also need to check peripheral pulses, distal to the repair site, to ensure good circulation. Patient teaching. For non-surgical patients, or as part of discharge teaching, lifestyle modification is everything. We need to help the patient decrease the stress on their arterial walls. Stop smoking. This is non-negotiable, as smoking severely damages the artery lining. BP control. Adhere strictly to the antihypertensive medication regimen and monitor blood pressure at home. Physical activity and weight. Encourage slowly increasing physical activity and maintaining a normal body weight. Lipid management. Follow the prescribed diet and medications to ensure lipid levels and cholesterol are within normal ranges. You've got the core concepts down: the pathophysiology, symptoms, and nursing priorities. Now, let's test what you've learned with 3 high-yield NCLEX-style questions that focus on the most critical nursing actions. Question 1. The nurse is assessing a client in the emergency department who reports sudden, severe back pain. Upon physical examination, the nurse notes a slight pulsation in the mid-abdomen. What is the priority nursing intervention? A. Immediately place the client in Trendelenburg position. B. Gently palpate the abdomen to confirm the size of the mass. C. Notify the healthcare provider and prepare the client for an urgent CT scan. D. Administer a scheduled PRN dose of a diuretic to lower fluid volume. The correct answer is C. Rationale. The symptoms, sudden severe pain, and a pulsating abdominal mass are highly suggestive of an expanding or leaking AAA. The nurse must immediately notify the provider. Palpating the area B is contraindicated as it risks rupture. The client needs rapid diagnostic confirmation to determine if surgical repair is needed. Question 2. A client with a newly diagnosed thoracic aortic aneurysm, TAA, is placed on strict blood pressure management. The nurse should explain that the primary goal of the aggressive antihypertensive therapy is to prevent which complication? A. Reducing the heart size to decrease oxygen demand. B. Promoting vasodilation to improve coronary blood flow. C. Minimizing the force against the weakened arterial wall. D. Preventing the development of peripheral edema. The correct answer is C. Rationale. The core pathology of an aneurysm is a weakened arterial wall. Aggressive BP control minimizes the systolic pressure's force against this weak spot, thus reducing the risk of dissection or rupture. Question 3. The nurse is caring for a post-operative client following an AAA repair. The client's BP is 118/72 mm Hg. HR is 90 BPM. The nurse notes the client's urinary output for the past 2 hours was 45 milliliters. Which action should the nurse take? A. Document the findings as they are within acceptable limits. B. Increase the rate of the maintenance IV fluid infusion. C. Notify the healthcare provider of the decreased urine output. D. Check the peripheral pulses distal to the surgical repair site. The correct answer is D. Rationale: client's total UO for the 2 hours, 22.5 milliliters per hour, is slightly concerning. We want 30 milliliters per hour. The most immediate postoperative priority in vascular surgery is checking for complications distal to the repair. A clot or graft occlusion could severely compromise circulation to the lower extremities, making a thorough assessment of distal pulses. Fantastic job getting through the complexities of aneurysms. You now know the key differences between AAA and TAA symptoms, and more importantly, the critical do not palpate rule and the signs of life-threatening rupture. Our next crucial step in cardiovascular disease is diving into the final consequence of all these risk factors: coronary artery disease, CAD, and the difference between angina and a myocardial infarction, MI. Ready to tackle heart attacks, or would you like to review the drug mechanisms for those antihypertensives one more time? Let me know.